Welcome to Thinking Thoracic, the podcast dedicated to exploring the advancements in thoracic surgery. Brought to you by the Society of Thoracic Surgeons. This podcast features leading thoracic surgeons discussing and debating the latest research, surgical techniques, and trends to expand your knowledge, challenge your thinking, and help you stay ahead of the curve. Whether you're a thoracic surgeon, advanced practice provider, researcher, or industry professional, Thinking Thoracic is for you. Let's get started. The Society of Thoracic Surgeons Thinking Thoracic podcast is sponsored by AstraZeneca.
Hi, everyone, and welcome to Thinking Thoracic, an STS podcast. I'm one of your hosts, Erin Gillaspie, and it's my absolute pleasure to welcome you. My co-hosts, Hari, Jeff, Jane, and I are so excited to bring you the latest and greatest in thoracic surgery. I am so delighted to be joining you guys today with Hari, one of my favorite people.
We're ready. We love this. We're here in New Orleans, and it's really exciting for all of us.
It absolutely is. You guys were at STS 2026, and we have seen so many incredible talks, great science, and of course, we get to reconnect with so many amazing colleagues and friends. And today, we could not be more delighted to welcome René Petersen to Thinking Thoracic.
Thank you so much for the invitation. I'm very honored.
Dr. Petersen is a professor of cardiothoracic surgery at the Department of Cardiothoracic Surgery in Copenhagen University Hospital, specializing in lung surgery. He holds a PhD in the field of video-assisted thoracoscopic surgery, as well as a bachelor's degree in healthcare administration. His primary research focuses on minimally invasive surgery, education, simulation, VATS, enhanced recovery after surgery protocols, and he is an absolutely brilliant researcher. I could not be more grateful that you're here today to talk to us about ERAS protocols and your incredible tubeless surgeries.
Thank you so much. I'm really looking forward.
Me too. I'm so excited to get our discussion kicked off. And if you could really just share with our viewers, you know, when we think about enhanced recovery after surgery, everybody thinks of this as sort of a very nascent field, but actually it has a much more long-standing history. Can you talk a little bit about sort of the advent of minimally invasive surgery, enhanced recovery after surgery programs, and how this inspired you to do some of the work that you're doing?
Yes, I certainly can. So we were early adopters of VATS in Copenhagen. So the first vasculopectomy was performed by my colleague Henrik Hansen in 1999, and gradually the program increased, and we were then realizing that as coming from thoracotomies to VATS, that suddenly the chest drain became very important because patients were actually very fit the day after surgery, but the chest drain was a limiting factor. So this inspired our interest for enhanced recovery. And in Denmark, we have the pioneer of enhanced recovery, Henrik Gillaspie, who's a professor of general surgery and has published more than 1,400 papers in enhanced recovery. And he's a great inspiration, and I've been working with him in research, and he's a wonderful mentor. And I think gradually after the minimal invasive surgery was implemented, we began to focus on some of the old dogmas that were limiting the sending patients home, discharging patients. And so one of the first dogmas was that we had 2 chest drains always for open surgery.
Yep.
And we reduced that to 1 chest drain, and everybody was like, oh, wow, that's dangerous. How, is the lung really going to expand? Are you going to extract all the fluid if you only have an apical chest drain? So actually, in the beginning, we made extra holes in the chest drain, because we were concerned not to drain the fluid, which we don't do anymore. It's not necessary at all. But this was kind of the first steps, and there's actually a very nice randomized controlled trial confirming this strategy. But it took a long time for people to get used to this. Then another very central dogma was the amount of fluid in chest drains. So when I was a young resident, when we were in the ward, the threshold was 150 cc's
Wow.
per day.
I think that still exists some places. I'll tell you that right now. It'll be like, 150 cc's or cc per kilogram or 2 cc's per kilogram, some random dogma, and people still do that.
Exactly. And then we gradually increased to 200 to 300. And actually, we did a study on 600 patients with a threshold of 500. And we could prove it was safe in that study. As long as it's serous, as long as it's not chyle or bloody, you should keep the chest drain in, of course. But if it's serous, it doesn't really matter. Nowadays, we don't have any upper limit for serous fluid. We only focus on the air leak. So this was also one of the dogmas that it took a long time to get rid of, but this was also advancing healthcare. Doing this observational study was proving this to be a good strategy. And then came a lot of questions, I think, around the perioperative management. So, for instance, for I think for decades, surgeons have discussed what is the optimal suction for chest drains. And this is something we spent entire conferences discussing. Some believe in a high suction, some believe in no suction, some believe in suction the first 24 hours and then no suction. And we had the same discussion in our ward among the surgeons. And once we got the digital systems, we could we could see exactly the pressure on and the air leak development. And so we conducted a randomized control trial. One of our PhD students, he did this, comparing a -10, which was the standard at the time, with the lowest possible suction we could apply in the tubeless system, and that was -2. And it may seem as a very simple study, but it actually proved that the low suction group did better. They had less fluid, they had less air leak, and shorter lengths of stay. So obviously we changed our policy, and now we use -2. We've since built an LVRS program, and there we really learned how dangerous suction can be for emphysematous patients.
Absolutely.
Probably if you have a normal lung, it doesn't really matter if you have high or low suction, but if you have a very emphysematous, very fragile lung, the suction sometimes can destroy the lung and destroy the tissue.
Absolutely.
So this was another dogmas that we investigated.
You've sort of tackled so many of the issues sort of surrounding chest tubes. So you're still putting patients on about -2, sort of post-operatively. Hari, out of curiosity, are you team suction or no suction? Do you do any suction?
We are team 24 hours of suction. Again, it's because my senior partner did that, and when I joined him, I adopted it. Like you said, it's just a dogma that we have kind of for no reason. When you talk about the suction, no suction, does it matter if you're doing an anatomic resection, a wedge resection, or type of surgery, or is this now everyone just goes to -2 on the TOPAZ?
Everyone goes to -2 now. Yeah, it's a standard. And I want to say also, when we moved from water seal systems to digital systems, we learned a lot about the physiology in the thoracic cavity. I think one of the major advantages of the digital systems is that anyone can read it. So we have a guideline saying that for chest drain removal, you have to have less than 20 milliliters of air leak per minute in more than 12 hours. So we have to see below 20 in more than 12 hours. And anyone can see that. So nowadays, I write in my OR report, if I do a lobectomy, segmentectomy, wedge, whatever, to the nurse, if there's less than 20 milliliters per minute in more than 12 hours in the morning and serous liquid, the chest drain can be removed. So when I come after our morning conference, chest drain is already removed and patient's ready to go home. So that's accelerating things. And I think that's a huge advantage if you standardize your protocols. It makes it so much easier. We're a large institution, so we're doing more than 1,200 major general thoracic procedures per year. It's just easier if you have institutional protocols that everyone can follow. And I think this is part of the secret of enhanced recovery success, is that you have these protocols and not individualized patient treatment.
Absolutely. Talk to us just a little bit more, because really we are seeing a big transformation from people using sort of the conventional, chest tube, water seal chamber, suction being separate, moving more and more to these digital platforms. But there is just a little bit of a learning curve in people sort of understanding how they work, what criteria it can capture for you. Because I think there's a lot of people that don't realize the amount of information you can truly gather from it to help with patient decision making. And you're right, it takes away that consternation of, is it chatter or is it true air leak? I mean, how many times has, all of us are told by our team members, oh, there's an air leak, and you come by and you're like, there is no air leak, that is definitely chatter. And it can be hard to sort through. So talk to us a little bit about how you guys successfully managed that transition, how you built some of those protocols, and what are some of your thoughts around the best pieces of data that you're getting out of that system, because it sounds like you guys are really using it effectively.
Yeah, well, I think we learned a lot from the digital systems, especially that you have the history, that you can look back 3 days to see the development of the air leak. And I think this is something that was inspiring us also to have a no chest drain policy, because in many of these wedge resections, we could see that from the moment you put in the chest drain, the air leak is zero. The fluid is maybe 100, 200, but the air leak is zero until you remove it the next morning. And then when you've seen that hundreds of times, you're wondering, do we really need that chest drain, in these cases? And this is what inspired us to do the feasibility study first. And of course, we were very concerned with this 1 in 100 or 1 in 200 patients after wedge resection who has a bleeding. And how can we capture this, because these patients are only in the recovery room an hour and a half, then they're sent to the ward.
Yep.
And if the nurses are busy, is there anyone attending? Potentially it could be a catastrophe because you don't have the chest drain to tell you that there's a bleeding. So what we did in that study was that we routinely did a chest X-ray 6 hours after surgery.
Okay.
And then always inform the patient, the nurses to look after the patients and observe them for bleeding, blood pressure, and pulse monitoring. So that's important, I think, because that's one parameter less you have to measure on in terms of bleeding.
Yeah.
So we were a little concerned also with the rate of reinsertion of chest drains, because it's so much less painful to have the chest drain inserted during surgery than afterwards. But we didn't see any in the 50 consecutive patients we did on the feasibility study. So that was very confirming. We were, however, very restrictive. So we knew also from the observation from the TOPA system that emphysematous patients, even after wedge, have air leaks. Deep wedges have air leaks. And if you have a lot of adhesions, you're also expecting air leaks. And this very narrow inclusion criteria. And this we also did in the randomized control trial, because it's not one size fits all. I think you have to look at the patient, you have to look at the quality of the lung if you want to have a no chest drain policy. And I think that's a very important point, because we have lots of problems with air leak in some patients.
Yeah.
Have you noticed anything with different staplers that you're using? Whether that's, I don't know if anyone does robotics or in reinforced staples. Have you noticed anything in that?
So we haven't used reinforced staplers. We've thoroughly discussed this in our LVRS patients, and I think we should do it actually, because we do have many air leak problems in these patients. We also have a PhD student who published recently our results with redo surgery after LVRS, and it's quite high, and it is carrying a lot of complications in this patient category. So I think for emphysematous patients, it makes sense to have a coverage of the stapler line. But one of the things we learned from LVRS is that instead of doing the traditional horseshoe, we do selected, based on the SPECT, we do selected resections peripherally, so we avoid tension on the staple line.
Yeah.
We do
That's
peripheral resections. And we could see in our study that this really decreased the air leak problems. Because these lungs are very fragile, and if you do deep staplings, they're going to burst the staple lines, even though you protect them, I think. So these are some things we learned. And also, I think using like long staplers, like 60 instead of 45 when you divide the parenchyma, is important because you get a more like natural staple line without interruptions, and in the interruptions, that's where you can get an air leak. So I think there's a lot of technical issues with your stapling that's very important, and also these new electronical devices that many companies have introduced, where you measure the pressure, and if the tissue is very thick, it slows down the application of staplers. And honestly, when we started with this, I thought, what's really the difference between the manual system and the automatic system? But I could do it slow, I thought, but you can't do it as slow as the automatic system. It just, when you look at the staple line, they're much better bend in this age configuration. That's really what you want. And for instance, for now that we have black reloads for segmentectomies, I always use the black reloads because there's so much pressure on the staple line in segmentectomies. So I think there's a lot of, it's a very good question, because there's a lot of tips and tricks to this that we can learn from and avoid air leak.
Yeah. So talk us through your protocol now. So you've got these beautiful inclusion criteria. So you're thinking slightly more peripheral wedge as a potential patient for inclusion. Not horrifically emphysematous lungs. We don't have tons of adhesions. So you're in the operating room now. You've done this beautiful procedure. How are you deciding today, in 2026, this is a patient that I'm going to consider for tubeless surgery at the end of surgery? And talk us through sort of that early postoperative protocol, how you're handling them in PACU. Are you still getting that chest x-ray at 6 hours? Sort of walk us through that decision-making in those steps.
Yeah, so we follow strictly the protocol from our RCT study. So one key parameter is to do the intraoperative air leak test, and this is absolutely key. So when you do a wedge, everything looks very smooth. Or I would say, when I do is the wrong term, because we always have a resident doing the wedges. So that's protocol also, that these are for residents, so that they can learn to do the VATS procedures. And so we're always supervising the residents when we're doing a wedge. But if you have a nice case, everything looks well, then we actually close as usual with a chest drain. We use, in these cases, we use a Charia 20 chest drain for these cases, and we use 5mm cameras. So we have small incisions, but we then close up, and then we put the chest drain under a water seal. It's just a basket with water, really. And then we ask the anesthesiologist to manually ventilate the lung, and then we compress the abdomen and the thorax, and we turn the patient so that we get all the air evacuated, because I think this is key, so you don't have a residual pneumothorax. You want the parietal pleura and the visible pleura to be stuck together, because that's the best sealant you can get. So you really have to be meticulous with emptying the thoracic cavity. And then we ask the anesthesiologist to apply a pressure of 20 millimeters of mercury and keep the pressure. And all of this procedure is around 5 minutes, so it takes a little time. Yeah. But if you're very meticulous with this, and then you can see that there's no air leak, then we remove the chest drain under pressure, under 20 millimeter mercury pressure, so the lung is expanded. But we still do the X-ray at 6 hours, and it's just to be on the safe side in terms of bleeding. The thing is, maybe it's not necessary, and maybe in number 500 it was necessary, and so that's what can you afford in that term? That's the thing. Yeah.
Well, the nice thing, X-ray on the whole, not even a procedure, right? It's a simple thing to get for a patient, gives the confidence that there's nothing, concerning from a clinical standpoint. I don't think it's wrong to get that. I sort of like the idea of having a chest X-ray. I know that it's a hot topic of a debate too, right? Like, should we get any chest X-ray? Should we get one? Should we get a pre-pull, a post-pull? Everybody's sort of talking about chest X-rays, but gosh, the timing of it's nice. It's 6 hours, gives you information about the patient. Clinically, they look great. To me, that sounds great.
Yeah, I think that sounds amazing. We're starting to dabble in our institution in chestless or tubeless surgery or same-day discharge. We're trying to get into that world, and I love the fact that you're doing this 6-hour X-ray. We did have a patient that bled once, and we were able to find that really quickly, went to the OR, same discharge the next day still because of that chest X-ray. So I'm actually very pro that. I think it's the right thing. I think patients like that, and it's good for us.
Now, in your study, one of the things that I noticed is that on that chest X-ray, sometimes you had just a little bit of degree of separation of the parietal and visceral pleura, right? Like, that's normal. We're doing chest surgery. We're in the chest. So commonly we see a little bit of air. How are you making decisions based on that chest X-ray if you should get another one, or if this is something that you're just going to clinically watch? Are there certain criteria that you're using for that, or does it just patient by patient where we're making sort of decisions?
So if there is a residual pneumothorax after the chest drain removal, we usually do an extra chest X-ray.
Okay.
So if this is, let's say, in the evening, we'll do another one in the morning, and just to see that it's not expanding, and then we can send the patient home. So it's just a residual air and not really an air leak. So this, together with clinical observations of subcutaneous emphysema or respiratory distress, of course, is important. But you're right, we see that often. But 2 chest X-rays with an interval in between assures you that this is not an expanding air leak.
Absolutely. And actually, I think there's great data coming out in this space to maybe suggest that we get a little bit too focused, I think, sometimes on the air in the pleural space. So there's an incredible researcher, Gary Lee, out of Australia, who is a pulmonologist. And he has actually developed a protocol now where he does not put chest tubes in for spontaneous pneumothoraces in the emergency room. And he walks a patient and he has a follow-up X-ray. And actually, even with complete lung collapse now, they are not putting in chest tubes if the patient meets their clinical stability criteria with no significant shift. And actually, as it turns out, all the patients coming back in on chest X-ray in a couple of weeks have a fully expanded lung. And so he postulates that actually perhaps that little bit of collapse is helpful to the lung to heal, and potentially even a lot of collapse, because what it does is it brings the alveoli closer together. So it allows to patch if there's a little opening there, allows our staple lines to heal and seal. And then that lung has an ability to re-expand and fill that space. I hear a lot of people talking about concerns of entrapment if we don't have perfect expansion, but gosh, I have never experienced that, to be honest. Even with a small pneumothorax patients go home with, their lung comes back up beautifully in their follow-up images.
Yeah, sometimes we have a residual lobectomy cavity, and it will fill up with serous liquid. But this is also, I think, a natural process.
Yeah.
So now, if I'm going to start a program where I want to start doing some of these ERAS protocols, next day discharge, tubeless surgery, what do you recommend? This should be like our first cases that we start doing this in.
So first of all, if you haven't, I recommend you to read the ERAS guidelines we published a few years ago. We're going to update them soon, but there are 45 items to enhance recovery, and it's graded according to evidence and recommendations, and it's a nice paper to read, and we follow this protocol, the guideline protocol, very strict. But yeah, I think we just had a discussion just before this with Erin that it's not one size fits all. I think that's a very important message, that we can't avoid chest drains in all patients, for sure not.
Yeah.
Some patients really need it, and so we have to individualize. But for instance, these wedge resections, simple wedge resections, where you're not doing any lymph node dissection because it's a metastasis, and you do a simple wedge. These are quite safe if you do a proper air leak test and you secure yourself with the chest X-ray. You can start with these patients, I think, if you want to do tubeless surgery. But also in all the other patients, we can reduce the size of the chest drains. We can accelerate the chest drain removal with these protocols, and which is also important because chest drains give pain, and we have this triad of chest drain, pain, and pneumonia, and we see that patients would have prolonged air leak. They usually they have a lot of pain because of the chest drain, and then at some point, if the pain treatment is not sufficient, they may develop a pneumonia, and so we've seen that also from our studies that these three things go together. So that's one of the reasons why it's so important to have an, let's say, aggressive and precise chest drain policy. I don't know if that answered your question.
No, that's great. No, that's exactly what I was thinking. These maybe metastastectomies where you have maybe a single metastatic site that you're going after, that might be the ideal case to start these types of programs.
And mediastinal cases where you didn't touch the lung at all. So why do you need a chest drain? Only to look for bleeding. But if you do a chest X-ray, you can avoid the chest drain in those cases, I think.
Absolutely. I'm so glad, going back to just a comment that you made, your ERAS protocol has 45 key points in it. And I think a lot of people forget that it's not just how we manage perioperative medications. It actually is a complete approach to the preoperative, intraoperative, and postoperative cares to help patients to recover more effectively by minimizing unnecessary lines, having the right size of tube, of course, making sure we have the right medications, moving them early, managing pulmonary hygiene. It really is a whole patient approach to recovery. And I think sometimes we forget that and focus so much on the medications that we forget about all these other really critical parts to it.
That's absolutely true. The first author of the guideline, Tim Batchelor, he's always comparing the ERAS program to these elite athletes, marathoners, etc., and how every little detail matters, and it's the gain of all the medical efforts. I think that's what is important.
Absolutely. Gosh, you've seen your program transform just unbelievably in your time there, going from open surgery to chest tubes, being pioneer in minimally invasive surgery, now moving into this phase of really sort of minimalistic small incisions, no tubes. What's next? What are you doing next?
That would be nice.
I'm so excited.
Let's hear the next frontier. What's going on now?
So we've been exploring. We built a program of single port robotic thymectomy last year. We've done 46 cases so far, and we just started doing subcostal lobectomies. Learned from Hyun Kim in Korea, who has a huge experience in the single port robotic system. And one of the things I really appreciate with this system is that you only require a single port, but once you get the system in, you actually have pretty much the same situation as in the 3-port VATS. You have 3 instruments, you have a camera you can move around. So it's very comfortable, it's very precise, but for patients, it's really minimal invasive. And so I think that's another, feature that's gonna increase our precision surgery, because I think that's where we are going from. We started on, let's say, very gross surgery. You did either pneumonectomy or lobectomy. These were the 2 procedures we did by thoracotomy 25 years ago.
Yeah.
And now we are doing segmentectomies. We're doing precise lymph node dissection. And I think these tools, the best or the most effective part of it is that they're so precise. They increase our precision. And I think the future for surgery is precision surgery and individualized surgery, especially with the development within the oncological field with perioperative treatments. And I think our role will be to be very precise.
Absolutely. I know. I love the way you describe, because I think of lung surgery, and probably this is why I love lung surgery so much, it's such an elegant surgery. It's a dance along the pulmonary arteries. It's that precise resection of lymph nodes. I love segmentectomy is one of my favorite surgeries that I do. And the more complex the segment, the better, because the anatomy is just spectacular. And it's such a precise, elegant surgery. I think for a lot of us surgeons, it's such an appealing case.
And also, we were just mentioning even what we consider simple cases, like maybe a wedge resection for a metastatic site. There's also a lot of nuances, and that part is pretty amazing, right? You've done so much research on just that alone, that very nuanced, what we consider a simple surgery.
Yeah. Right stapler, right approach, right incisions, right perioperative management. You really can make such a difference by optimizing every single part of the case.
Exactly, and I may want to add a comment to that.
Yes.
If we're talking about lengths of stay, we discussed this just before. So we are using lengths of stay as a parameter to evaluate our enhanced recovery program. But it's just a word of warning. I think this is not necessarily equal to a successful enhanced recovery program. You can force your patients home early if you want, but what you should really achieve with your enhanced recovery program is that patients want to go home. So they should be treated so well, the pain treatment should be so good that they're asking to go home. That's the optimal situation. I think that we make patients ready to go home and not force them out, because sometimes we operate on elderly patients nowadays. We've just published a paper on octogenarians, and we just could see how the last 10 years we are increasing the number of octogenarians that we operate on because we can.
Yeah.
There are good results. There are low morbidity, even in 80-year-olds with comorbidity. We can do rather safe cases, and these patients sometimes require a little extra care, like maybe an extra day in hospital, and I think this is important to understand and embrace. So even though we have a median length of stay of 2 days after lobectomies, there's still a variety. So there's this young patient who may go home within 24 hours, and then you have an 80-year-old which needs an extra day or two. But the thing is, again, it's all about also accelerating their chest drain removal, so they get rid of the pain and you optimize them. But it's been discussed a lot, but I think it's just important to mention that length of stay is not always the parameter you should look at. It's actually, I think, what is most important is that you do not have any complication and a good outcome. That's the most important part, I think.
Absolutely. Patient outcomes, patient success, and safe transitions home. And the reality for a lot of us, and I know you are included in this, our patients don't always live right next to the hospital. And so making sure that we are setting them up for success and not always hanging our hat on a perfect number, but rather a perfect patient outcome actually is a much better barometer for all of our success.
Yes.
I love that.
Couldn't agree more.
I love that.
Yep, that's what it's all about the patient.
Yeah.
That's right. Well, gosh, this has been such an extraordinary discussion. If you have one, important message that you want to leave our listeners with today, what would you like to share with them?
So, I would like to address the young generation. We saw just this morning an undergraduate student performing perfectly on the main stage.
Amazing.
And I think to the young generation, we can say that the field is moving so fast right now. There's so many things going on in thoracic surgery. It's amazing. I think I enjoyed being part of this journey of minimal invasive surgery during my career, but I see now so many things happening, especially within the oncological field, and the survival and the efficacy of treatment lung cancer is improving day by day. And so I really encourage the young generation to be involved with thoracic surgery. It's a wonderful field.
Couldn't agree more. Couldn't
Perfect.
agree more.
It's perfect. Yes, we truly are blessed to get to do what we do every single day. Well, you guys, another incredible discussion, another incredible podcast. Thank you so much for joining us. To all of our incredible listeners, have a wonderful rest of the day. Please continue taking incredible care of our patients. Please keep educating people about lung cancer screening. It's so important. Keep taking extraordinary care of each other. And of course, keep smiling. To our amazing listeners, thank you so much for joining us today. If you have enjoyed the conversation, please be sure to follow Thinking Thoracic on your favorite podcast platform so you never miss an episode. Your support helps us to continue to grow, improve, and to bring you the most insightful conversations. And if you have a moment, we'd love for you to leave a rating or review. It really makes a difference. Thanks for tuning in, and we'll see you next time.
Thank you for joining us on this episode of Thinking Thoracic. The opinions expressed in this podcast are those of the participants and do not necessarily reflect the views of the Society of Thoracic Surgeons.